topic for discussion now is again dysfunction of thyroid and parathyroid glands. Here in one of the presentation we actually seen about various tumors that are affecting the thyroid and parathyroid. Here we will be seeing about the various swellings and also how the dysfunction of thyroid and parathyroid glands are actually happening. So before going into the thyroid dysfunction, thyroid gland is actually a highly vascular organ which is present in the front side of the neck and also on the lower side of the neck region. Normally this thyroid has two lobes which is connected by an isthmus, and behind the thyroid we have four small glands which are nothing but parathyroid glands. And this thyroid gland is actually covered with two kinds of capsules. One is a true capsule and one other is a false capsule, and it is being covered by the pretracheal sheath of the deep cervical fascia. So not going much into the anatomy of it, this thyroid gland, as we all know, the most important, the principal hormone that has been secreted by it is thyroxine, and it is made up of the iodide. Okay, the iodide is the most common ingredient of this thyroxine hormone. And we have the thyroid system. How it actually works is, from the hypothalamus we have thyrotrophin releasing hormone which will actually stimulate our the pituitary. Okay, in this pituitary what happens, we have this thyroid stimulating hormone which will cause effect on the thyroid gland, leading to the release of thyroxine hormones, that is T3 and T4. Okay, these T3 and T4 are responsible for the maintaining various bodily functions. We have these thyroid hormones have effect on the nervous system. They have effect on the maintaining the calorogenic effect of the body, that is maintaining the temperature. It also have the effect on the basic metabolic rate. They have effect on the carbohydrate metabolism. We have on the cholesterol metabolism, on the catecholamine metabolism, and also on the growth and development of the body. So such important is our thyroid hormone. And the parathyroid glands actually release a hormone called as calcitonin. Especially they are released from the parafollicular C cells. Okay, these are the parafollicular C cells are the one that will release the calcitonin hormone. This calcitonin hormone is responsible in maintaining the homeostasis of the calcium metabolism, especially from the bone. Okay, these are the thyroid system and also the parathyroid system. So entering into various dysfunction, we have two main dysfunctions. One is we have the hormonal imbalance there itself. That is, in case of thyroid, we can actually have hyperthyroidism and hypothyroidism. Okay, in the parathyroid hormones, we have hyperparathyroidism and hypoparathyroidism. Apart from this, we have certain other diseases where we actually see enlargement of thyroid gland which can cause goiter. Okay, these goiters can be simple goiters or multinodular goiters, solitary nodular goiters. We have thyrotoxicosis. So today we will be dealing about this segment of the thyroid dysfunction. So coming to goiter, goiter is actually it is actually derived from a Greek word which means gutter. Gutter is actually meaning neck. However, in the flow of time, what happened is any benign swelling that is present within the thyroid is known to be called as goiter. Now this goiter is nothing but a benign diffuse enlargement of your thyroid gland. Coming to the classification of this goiter, we have a broad range of classification where simple goiter includes again has a classification of colloid goiter, we have puberty goiter, we have multinodular goiter or iodine deficient goiter. The simple goiter is one which is most frequently seen. It is actually usually a solitary or multiple nodular kind of swelling will be seen, especially in the thyroid region, in the anterior part of the neck. In case of this colloid goiter, what happens is, in the colloid goiter, the material that is being present, the gland itself is so soft, it has a smooth texture, and in consistency it is usually softer in consistency. This colloid goiter usually has a manifestation of hypothyroidism. Okay, the amount of thyroid secretion, the thyroxine secretion, thyroid hormone secretion is usually less in case of this colloid goiter. The puberty goiter is, as the name itself indicates, usually seen in young adolescent females, especially at the time of puberty age group. In those age group we actually see this simple goiter, simple puberty goiter. The main reason for this goiter, especially the simple goiter, is there is increase in stimulation of thyroid stimulating hormone. Why will be there will be increased secretion of this thyroid stimulating hormone? Whenever there is decreased circulating thyroid hormone within the body, what happens is it sends a positive feedback to your the pituitary gland, where it releases thyroid stimulating hormone. Because of the release of thyroid stimulating hormone, it continuously signals the thyroid gland to release more and more amount of thyroid hormones. So because of this increased workload, what happens, there can be hypertrophy and also hyperplasia of the thyroid gland, leading to this simple goiters. Okay, so this increase in TSH hormone could be of any reason. Any reason that is actually causing this increased TSH will in turn lead to simple goiter. And this simple goiter, as I told you, could be a single one, a solitary nodule kind of thing, or it can have multiple nodules within the thyroid gland, which is nothing but your multinodular goiter. Next is iodine deficiency goiter. As we all know, this the iodine that is being taken through food, 98% of this iodine is converted into iodide, and it is being taken up by the thyroid gland completely in the production of the thyroid hormones. That means all the amount of iodine is converted into thyroid hormone, right? So if there is any deficiency of this iodine within the food intake or within the daily requirement, if it is not met, in those cases also we can see this iodine deficiency goiter. This iodine deficiency goiter can be endemic in some cases. For example, in areas of Great Britain, in areas of Asia, in some few countries in Asia, what happens is in African countries also, there is deficiency of this iodine within the food, thus leading to this endemic goiter that is present within a localized area, endemically within that particular place. Next, we have something called as toxic goiter. In this toxic goiter, also called as thyrotoxicosis, where there is excessive release of this thyroid hormones, usually seen in case of solitary toxic goiter. We have Graves' disease, also called as one of the form of thyrotoxicosis. We have secondary thyrotoxicosis also, especially in case of your multinodular goiters. And this multinodular goiter is usually more commonly encountered in females, especially at the age group of late 30s and 40s. And this multinodular goiter, they have diffuse hyperplastic lesions, diffuse hyperplastic goiter. Multiple nodules can be seen in one single lesion, but when we palpate, we actually find multiple nodules within this region. There is something called as Pendred syndrome. In this Pendred syndrome, what happens is the patient usually will be deaf. There will be goiter since the time of their infancy. They have this Pendred syndrome, and then we have. As I told you, there is secondary thyrotoxicosis in case of this multinodular goiter. Why? Because there is excessive release of thyroid hormones as a response to the thyroid stimulating hormone. Next one is neoplastic goiter. In this neoplastic goiter, we again have benign lesions and malignant lesions. In the benign, we have well differentiated and poorly differentiated carcinomas that have been associated with the lymphatic system, whereas in malignancies, we actually see something called as metastatic melanomas. Okay, these are various neoplastic goiters. And then we have thyroiditis. Thyroiditis is again inflammation of the thyroid gland. It can be of various reasons. One is granulomatous infection, or it can be because of an autoimmune disorder. This autoimmune disorder, what happens, will be increased circulating TSH antibodies, that is thyroid stimulating antibodies. When there are more amount of this thyroid stimulating antibodies, what happens? They go and bind to the receptors of the thyroid producing hormone producing receptors are bounded with this thyroid stimulating antibodies. Thus, this will cause thyroiditis again. Most commonly, Hashimoto's thyroiditis is one of the most common autoimmune thyroiditis. We have something called as Riedel's thyroiditis, and in miscellaneous conditions of thyroid, we have thyroid cysts, we have thyroid abscesses, amyloid goiters. As we know, there will be deposition of this amyloid material within the thyroid gland, leading to swelling, which can be edematous, soft, smooth surfaced, and also a swelling can be seen in the thyroid region because of this amyloid goiter. And amyloid goiter, by the time we actually encounter an amyloid goiter, there can be a diffuse deposits of this amyloid material in various internal organs and viscera. There can be tongue amyloidosis associated with this amyloid goiter. In coming to multinodular goiter, it is actually a sequelae of your diffuse hyperplastic goiter. As I told you, it is more commonly seen in women, especially in the late age group of late 40s and 50s of age group. And this multinodular goiter usually also been seen associated in case of this puberty and also during the pregnancy. Whenever it is associated at the puberty age group, it is called as puberty goiter, and when it is associated in case of the pregnancy age time period, then it is called as pregnancy goiter. And this is a picture which is actually showing us multiple nodules. There is actually a uniform single swelling which has multiple nodules present in this thyroid. And coming to investigations, we have various investigations like complete blood picture as can be taken, and we have X-ray of neck. In the X-ray of neck, what happens is when we take a plain neck view radiograph, in that we can see a soft tissue swelling, especially at the region of thyroid. The lateral X-ray view and also the straight anterior posterior X-ray view will also help us in identifying any soft tissue mass which has been present. And then we have indirect laryngoscope. Indirect laryngoscope will help us in identifying any neck masses that are present. Ultrasound can also be done. Ultrasound will actually delineate whether the mass is, whether it is a cystic mass or a solid mass. And the most useful or most followed investigation for this thyroid ones is radioisotope scanning. Radioisotope scanning will actually use iodine 131 isotope is used in these cases, and the position of this iodine 131 in various regions, like especially in case of thyroiditis or autoimmune thyroiditis, we actually have a speckles of this iodine 131 being deposited within the thyroid. So these are various investigations that can be done in identifying the thyroid diseases. Now coming to management, whenever we see these goiters, normally in case of goiter, usually these goiters are irreversible, they cannot come back to a normal state. However, we can actually decrease the size of the goiter before going into a surgical excision. So how do we decrease? We actually give a thyroxine as in higher doses, especially in the dose of 110, 100 to 130 milligrams of iodine is given, and it will decrease in size. When it is actually decreased in size, then we can go for surgical management of this. How do we go for surgical management? We actually do initially we can do a lobectomy if it is one particular lobe is being involved. However, in goiter, as I told you, if you remember, it is actually a uniform one, right? But it might have multiple nodules within it. It's actually a solitary swelling with multiple nodules. So in those cases, what we do is we do a subtotal thyroidectomy. When we are doing the subtotal thyroidectomy, what would be the complication? Definitely the thyroid hormones will not be present, right? We are decreasing the level circulating thyroid hormones. Again, what happens when there is decreased circulating thyroid hormones? Your pituitary will release your thyroid stimulating hormone, which itself is a goitrogenic one. So, to reduce that, what we have to do is, we have to give a suppressive thyroid hormone replacement therapy for lifelong, about 0.2 milligrams of thyroxine as a precautionary one to decrease the TSH levels after the surgery. Okay, so this is about the management of the goiter. Okay, simple or nodular goiter. Now coming to retrosternal goiter. Retrosternal goiter is, the name itself is telling, it is actually present deep into the into the fascia. It is actually present just above the sternum, deeply present. And this retrosternal goiter usually seen in case of men when they actually have this negative intrathoracic pressure. Usually because of this negative intrathoracic pressure, they have this retrosternal goiter, most commonly seen in men. There are various types of this retrosternal goiter, and these includes substernal goiter, we have plunging goiter, we have intrathoracic goiter. Substernal goiter is usually present behind the sternum. That's why it has this name substernal. Plunging goiter is something which is also present behind the one. To actually tell you, in the substernal goiter, when we actually put the finger and palpate it is behind the sternum, we can actually find the mass, the retrosternal goiter. But in case of plunging goiter, when we actually try to palpate for the goiter, we will not be able to palpate it unless the patient, does a secondary maneuver like cuffing, or when there is increased, again, there is change in the intrathoracic pressure, it actually plunges out, it actually pops out from the substernal region. Only then we can palpate. That's the reason it is called as plunging goiter. And we have intrathoracic goiter, which is actually deeply placed or deeply situated, which cannot be palpated by manually. Okay, we cannot do it manual palpation in case of this intrathoracic goiter. Now, we have various clinical features for this retrosternal goiter. As I already told you, it is a lump present behind the sternum, right? It is in the usually the lower border of the swelling is not seen. So what happens, because of the lesion that is being present retrosternally, it is actually a space occupying lesion. For example, if the lesion is present on the anterior part of your thyroid, the lesion grows outwardly. But here, because it is present behind the sternum, what happens? The sternum, the bony compartment is present, which is not allowing an anterior enlargement. So it goes posteriorly. Then it will have characteristic pressure effects. Remember, the retrosternal goiters usually have the pressure effects. Okay. What are the various pressure effects? Dysphagia, obviously. Patient will have difficulty in swallowing because of compression of your, esophageal part. Behind esophageal part is being compressed. Patient will have dyspnea. Why? Because the tracheal compartment is again being compressed. The tracheal compartment is obstructed. And because of this obstruction or because of the pressure effect, what happens? The surrounding veins, the neck veins usually have engorged. They actually swollen and they become tortuous, resulting in engorgement of neck veins, which is nothing but Pemberon sign. Pemberon sign is again a characteristic feature of your retrosternal goiter. Next is toxic goiter. Toxic goiter, also called as thyrotoxicosis. In this thyrotoxicosis, it is nothing but there is accumulation of clinical manifestation because of excessive secretion of active thyroid hormones. The thyroid hormones are produced so abundantly, which will lead to thyrotoxicosis. That is, toxic level of thyroid hormones is being achieved in case of this thyrotoxicosis. It is again grossly divided into primary and secondary. Usually this, the thyrotoxicosis is caused because of a solitary toxic nodule, sometimes also associated with multinodular goiters. Okay, and we have other miscellaneous causes for this thyrotoxicosis. We have thyrotoxicosis factitia. Thyrotoxicosis factitia is a condition. Usually it is associated where patient is being taking increased dosages of thyroxine hormones. The replacement thyroxine hormones are being taken in increased dosages, then it results in thyrotoxicosis factitia. Another condition is Jod-Basedows thyrotoxicosis. This Jod-Basedows thyrotoxicosis is a sudden abuse. Remember, there is a difference between this thyrotoxicosis factitia and Jod-Basedows. What is the difference? In thyrotoxicosis factitia, patient is being taking the medication chronically in a higher dosage. Whereas in Jod-Basedows thyrotoxicosis, it is a sudden ingestion. Okay, it is an acute condition. To be precise, it is an acute condition of a thyrotoxicosis. And we have neonatal thyrotoxicosis also, usually seen in a newborn infant child, where there is sudden, because of already patient would have a goiter there, and there will be increased amount of thyroid hormones secretion in case of this neonatal thyrotoxicosis. Next is Graves' disease. Graves' disease, you have again different etiological factors. It could be autoimmune, it could be familial, it could have immunoglobulins which have been associated with it. That is nothing but thyroid stimulating hormone immunoglobulins, and we have exophthalmos producing substances. Graves' disease is actually a triad. It is a triad of exophthalmosis, it is a triad of skin, and it is a triad of increased hyperthyroidism, increased thyroid hormones. The clinical features will actually be, patient will have swelling, unexplained weight loss will be seen. Patients can have diarrhea because of increased motility, and they have intolerance to heat. Because of hyperthyroidism, they have intolerance to heat. Tremors will be present, fine tremors to the hands. Patients are so anxious, they feel stressed out, and this thyrotoxicosis exophthalmosis. Exophthalmosis is nothing but popping out of the eyeball. Okay, that can be seen in case of this Graves' disease. Now, this exophthalmosis assessment, how do we do? Because I told you it is one of the pathognomic feature. It is actually identified or characterized by a triad. So one thing, hyperthyroidism, that we could actually do it by a serological or biochemical examination. The exophthalmosis assessment has to be done. This exophthalmosis is actually of two types. One is true exophthalmosis and one is apparent exophthalmosis. In true exophthalmosis, what happens is there is accumulation of fluid in the retrobulbar region of the eye, resulting in proptosis of the eye. That is resulting in outbursting of the eye. That is nothing but true exophthalmosis. In apparent exophthalmosis, what happens is there is actually no retrobulbar accumulation of fluid or anything. There is actually spasm of the muscles of the upper and lower eyelid. Thus will actually contract your eyelids like this. So the eyelids are actually contracted. Thus the eye appears to be bulging out, it is actually coming out. So that is nothing but apparent exophthalmosis. And for this exophthalmos assessment, we have various signs like I told you. One is Mobius sign. So what is this Mobius sign? Mobius sign is actually a condition where the convergence of eyelids does not happen. Okay, patient cannot get this convergence of eyeballs, actually it is absent in case of this Mobius sign. And we have Stelzach sign. Stelzach sign is actually nothing but staring type of look. Patient will not have that blinking as a normal person has, the decreased blinking effect, decreased blinking. In case of this Stelzach sign, patient will have a characteristic staring look. And we have something called as Jaffrew's sign. This Jaffrew's sign is nothing but when patient is asked to look upwards like this, there will be absence of wrinkling of the forehead, which is a characteristic sign, which is nothing but Jaffrew's sign. When we have Van Graff's sign of exophthalmos assessment is when the patient is asked to look downwards, this eyelid will not follow the normal rotation of your eyeball. Okay, that means when we actually looking down, immediately the eyelid falls down, right? There will be lid lag. There is lid lag in case of Van Graff's sign, where the eyelid will not take a normal downward rotation. Immediately it will not take a rotation of your eyeball. So this is about exophthalmos assessment. We have something called as malignant exophthalmos. In this malignant exophthalmos is what happened. It is again a combination of signs, which is nothing but we have chemosis and we have congestion of the conjunctiva. There is redness and erythema, especially venous congestion is seen of conjunctiva, and edema of eyelids is present. This triad is nothing but malignant exophthalmos. And as I told you, hyperthyroidism we have checked for exophthalmos. I told you there is something of a dermopathy sign, right? This dermopathy sign is nothing but pretibial myxedema. Pretibial myxedema is nothing but the swelling of your skin, especially of the lower part of the limb. Okay, here there is a swelling of the skin because of the mucinous accumulation in it. This is nothing but pretibial sign, pretibial myxedema, which is again a characteristic feature of our Graves' disease. Okay, so these are the three triad. And coming to the management, how we do, we have actually we load the patient with steroids. There will be massive doses of steroids are given. Lateral tarsography to treat the exophthalmos, and we give guanethidine eye drops, especially to prevent the dryness of eye, because the eye is completely, the conjunctiva and the sclera is completely exposed, more amount of exposure to the external environment. We give this guanethidine eye drops. And for thyrotoxic myopathy also we actually do the management. And pretibial myxedema, I told you that the legs, the lower part of the leg is actually being mucinous deposition is present in these cases. The whole treatment, what we do is, because of this hyperthyroidism, we actually give medication to reduce the increased amount of thyroid and also to reduce the inflammatory action that has been happening. For that, the massive doses of steroids are being given, which about the dosage of 1 gram per kg body weight has to be given to the patient. And then next one is autoimmune thyroiditis. In this autoimmune thyroiditis, as I already told you, the most common one is Hashimoto's thyroiditis. In this Hashimoto's thyroiditis, what we see is there is extensive lymphocytic infiltration. Extensive lymphocytic infiltration or chronic one, or lymphadenoid type of goiter is seen. And most commonly the autoimmune thyroiditis affects women, especially in the pre-menopausal stage. And the characteristic feature of this autoimmune thyroiditis is there is increased thyroid antibodies circulating within the body. Okay, increased thyroid antibodies. And when we actually go for histopathological examination, we have something called as Ashkenazi cell. This Ashkenazi cell is nothing but oxophilic cells, which is again a characteristic feature of this autoimmune thyroiditis. And next we have Riedel's thyroiditis. Riedel's thyroiditis is a very rare condition. It is actually a collagen disorder. Along with the mediastinal and retroperitoneal fibrosis in this condition, we actually see sclerosing cholangitis. Okay, Riedel's thyroiditis, we actually have a triad. We have a sclerosing cholangitis, we have mediastinal and retroperitoneal fibrosis. Because of this, what happens, mediastinal and retroperitoneal fibrosis, there will be, patient will have difficulty in swallowing, that is nothing but dysphagia, and also respiratory stridor, dyspnea will also be seen in case of this Riedel's thyroiditis. And I told you that the surgical management is thyroidectomy. Usually we do subtotal thyroidectomy, right? But this have certain complications. Other than the decrease in circulating thyroid hormones, we have certain other complications of this thyroidectomy, which includes hemorrhage. There could be respiratory obstruction. Because of this after the thyroidectomy, what happens is there can be edema in the immediate post-operative section. There can be respiratory obstruction, voice change, because if when we are actually doing thyroidectomy, there can be unintentional harm to the vocal cords, especially the arytenoids, which can lead to voice change, where patient will have a whispering type of voice. This whispering type of voice is usually because of the nerve damage, that is nothing but your recurrent laryngeal nerve palsy. This recurrent laryngeal nerve palsy can be either unilateral one or bilateral one, which can result in whispering type of voice change. And then as I told you, permanent hypo or hyperthyroidism. That is the reason we actually have to give the patient a suppressive thyroid hormone regimen also. And thyrotoxic crisis can be present. Thyrotoxic storm can also be actually encountered, which is actually a potential fatal condition when patient is not kept on suppressive thyroxine medication. This suppressive thyroxine medication dosage could be 0.2 milligram dosage. Okay, this dosage is actually enough for the suppressive thyroid regimen. And then we have other complications like infections can be present, scar can be evident sometimes, and sometimes we actually can go encounter a suture granuloma. So this is about various conditions that are usually encountered. Apart from your hormonal and apart from the tumors, the other swellings or benign lesions that have been encountered with thyroid. So this is about the various dysfunction of thyroid gland and also parathyroid.